This is Sam Robson. It is March 22nd, 2017, and I have the pleasure of sitting down with Mr. Osman Barrie here in Cambia, Sierra Leone. This interview is part of our CDC Ebola Response Oral History Project, and thank you so much, Mr. Barrie, for joining me for the interview.
Thank you very much.
Of course.
Sam.
Would you mind just first saying, my name is, and then just saying your name?
Okay, my name is Osman Barrie. I am the district surveillance lead for Cambia district, and I am based in Cambia town, and I work for the Ministry of Health and Sanitation with the district health management team Cambia here.
Perfect.
Yes.
We have an interruption? Okay. And if you could summarize your Ebola experiences in just 2 to 3 sentences, what would you say?
I would say the experience gained from the Ebola in Sierra Leone, specifically Cambia, it's been an experience for future development in terms of surveillance activities. You know, it has actually opened up my eyes in the event of epidemiology, and it's something which everybody may actually want to be part of because it's very interesting.
Thank you. And so I'm back with Mr. Barrie, and I'm wondering actually if we can talk a little bit about like your life before Ebola. Can you tell me when and where you were born?
Okay, thank you very much. I was born in the southern part of Sierra Leone in a small village called Tayama in Kore Chiefdom, Moyamba district. I head up in the south, specifically in Bo, that is the second capital city of Sierra Leone. I went to my primary, secondary, and university education at Njala University, Sierra Leone, and I happened to study community health and clinical sciences.
Why did you get into that? Why were you interested in that work?
Yeah, because it came about as a result of one of my aunts that was very ill. We went to the hospital, and a lot of things happened that never went down well with me, and I was thinking if I could have the opportunity to be part of the medical system, maybe I could change something and do something better. So that was where I got my inspiration from, and as God may have it, I had support from my elder brother after taking my works, that is the GCO level exams, and I enrolled into the program at Njala University. The program, when it started in the 80s, it was only having a diploma level courses, and by the time I enrolled, it was at higher diploma level, and only now they have upgraded it to a BSc level, which I am still intending to go and have because it's very interesting, and it has a lot to do with community people, community involvement, community entry, a lot of community activities. So, and dealing with local based people, you have to have the behavioral practices, the health practices, I mean, of these community people, so that you can actually deliver the health service you intend to deliver. So as a young man coming from a village, I think it was very inspirational to study about community, local community people. So that's where I got my inspiration, and I went through the university, and as I graduated in 2010, I happened to pick up a job with a local NGO that was also doing with community activities, that is an integrated community case management. They call it ICCM, integrated community case management, where we were visiting communities, selecting community volunteers, that is community leaders themselves, appoint somebody to be trained and be giving basic treatment for malaria, diarrhea, and pneumonia for under 5 children. So we were on those on that particular activities until 2012, and I decided to join the ministry because I was still not very comfortable. Even though I was dealing with community, but my clinical skills were dwindling because I was not practicing enough clinical activity. So
what was your role with that organization?
What was to train I was a supervisor training chiefdom health workers and training community health volunteers that will be delivering these health services in terms of treating children for malaria, pneumonia, and diarrhea. So it was just like that, those basic tablets given to the students. So I said, okay, now I have learned a year plus about the community. I want to go back to a clinical field where I can really practice my clinical work. And I happened to come back to the referral hospital in Cambia here. And I spent a year in the hospital seeing patients of different kinds, treating, referring those that need referral to tertiary level in Freetown. And from there, the district health management team thought it wise that, okay, I am fit to head chiefdom, because the district political division is like from national level. They have regional divisions. That is, we have the east, west, north, and south division, and in each of these divisions they have districts in each of these regional divisions, and in each district they also have a chiefdom level division, which a whole chiefdom may have 10, 5, as the case may be, health facilities in those chiefdoms, which is also having a local administrative structure that is headed by the paramount chief. Every chiefdom have got a paramount chief, and in those chiefdoms also they have section division, which they have section chiefs, and in each section we have villages. Yes, so I was asked to head one of the chiefdoms as a chiefdom health supervisor, even though I was in charge of one of the BEMOC facilities in Bremaya chiefdom. So I was transferred to Bremaya chiefdom and overseeing the other health facilities, the maternal and child health post. I was heading the referral center in that particular chiefdom. So cases that are beyond their knowledge, they have to send them to me. And if I try also, I have limited services in my health facility, I will transfer such case to the district headquarters here, especially cases that need surgical interventions. So we were on that till 2014 when we have a big strike of Ebola in the country. Yeah, of course. The chiefdom I was heading, we had 5 cases, 5 confirmed cases of Ebola. As the head of that chiefdom, I tried as much as I can with the involvement of community stakeholders, the involvement of military personnel in that chiefdom, and the youths in that chiefdom. All the 5 cases, I was able to control and had no secondary infection from all those imported cases. The first case that was seen, I saw it in my health facility, that was from Freetown. Immediately isolated the case, make an alert here, sample was collected. I spent 3 days with that case in the health facility, in that isolation. I was giving treatment to that person. Luckily enough for me, I just happened to got a training on IPC that very week. So my return, I had to detect that case and I was treating that patient.
How were you protecting yourself with IPC?
I was using the full PPE. You know, when they came, they had a supply, massive supply of PPEs before we started having Ebola in Cambia district. So we were having the boots, the hard gloves, this overall people wearing. We have the face shield, those goggles, and face masks, and the rest of it.
Those were provided by whom? Sorry.
They were provided by the ministry through other donor partners like the WHO, the World Bank. These were the partners at the initial stage that were providing the support for the ministry. And we happened, luckily enough, to have those supplies in the district, and we took the supplies to our various facilities. And that very week, I had a first case. That case spent 3 days with me in the health facility. By then, the only lab in the country was in Kenema, and the only treatment center was in Kailam. So that case, after spending 3 days with me in the isolation unit, because I used a newly constructed toilet building which was not used as an isolation because the health facility was very tight. So, but I think that was wise enough because the health facility was tight. There was no place to put patient of that nature, and I wouldn't want to allow that patient to be interacting with other patients in the facilities. So I had no option, but the patient was kept in that particular place. Until after 72 hours, in the early hours, around 5 a.m., I got a call from the lab that the patient I'm having is a confirmed Ebola patient. Oh my God. That was something. I was alone in my room. I started thinking how I was dealing with the patient myself, trying to evaluate what I was doing. But on the whole, even though I was not 100% confident that I may have done the right thing, but I was still scared somehow. Yeah, notwithstanding, an ambulance went and picked the patient. Of course, the family members were cancelled immediately. Fortunately for the community people, the patient from Freetown came directly to Kukuna community. That very day, they brought the patient in the evening hours. So the contact with family members and the family was so slim, was very limited. The interaction was not that much. So the patient was taken to me. I immediately isolated, explained to the relatives why I had to do this. Of course, in the country, it was on the news that Ebola is a very deadly disease and people should refer patients to health facilities immediately as they detect cases. So to that community, I was so happy with them.
Can I ask, how did they react?
So actually, it was not really easy as someone may think, because you have your loved one and someone is sick. You used to take care of your loved one, and somebody is stopping you not to go closer to your loved one. I mean, it was very, very challenging. But the community have quite a lot of confidence in me, because before Ebola cases, I've had so many engagement with the people in that community in relation, preparing their minds if we have any case of that nature, what will happen. So they saw the practical reality of the things I was telling them, and I told them that it was not out of malice, it was not out of any form of hatredness, but it was because of the policy to save myself, to save the family and the community at large. So even though it was never well done with them, but they accepted and they keep to the rule. The lab patient was picked up. Unfortunately, the patient happened to die in the treatment unit. And the family members, I could remember we have 19 people quarantined to be followed up in that community. Unfortunately for us, they went through 21 days and without anybody, even a child, manifesting any signs and symptoms. So after that, we actually said, okay, the wife that was living with the man, we said maybe they may have had, because the closest person to the husband could be the wife. We said, let's observe her for another week or so. So she was observed alone, followed up, and nothing happened. And even up to date, she's very okay. That was the first case. And the district was so worried about me, the district head management team, thinking that maybe I may have done something wrong. The DMO by then called me personally on phone, asking, trying to know how I was dealing with the patient. And I actually told him what I did, even though I was not 100% confident, but I think there was nothing to point at to say I may have become contaminated. But notwithstanding, I was advised to observe myself for a period. And that I did, and nothing happened. Okay, so the second case happened at Bulun community in one village called how is it called now? Bulun community. Bulun is one of the PHUs we have, and the community people made a call to the health facility, and the nurse was competent enough to inform me. I came right there immediately. Went to the community, saw the patient, classical signs and symptoms. We have to make a call, also follow up the family members. There was no secondary infection. So, in summary, all the 5 cases we have in Bremen achieved them within 2 months period. There was no secondary infection. We followed up all the cases, the contacts. I mean, there was no secondary infection. And the district said, what is the magic? What is the magic I am playing? Because if other chiefdoms, when they have cases, they have a lot of secondary cases coming up. So the DMO himself and some few members of the DHMT went to me at the health facility. They asked me this question: what is the magic that I'm not having any secondary infections? Well, the first thing I told them was, first of all, pre-engagement of community people about what you are foreseeing to happen in the future is very, very key. It's like preparing the mind of a husband that is trying to get married to a woman. You know, counseling what you may envisage during the marriage period is very important. So something like that I told them. That we've had a lot of community engagement here, and I have personally been moving around the community, engaging stakeholders with pictures about the disease that has erupted in the country. So with that, they were having so much confidence in me, and they have seen evidence of me dealing with cases that are confirmed to be Ebola. So that was the first thing I told them, that building people's confidence before situation happen, it is very key, very important. So they say, all right, if that is the case, then they will implement similar things. So these were happening. That was the time a lot of proposals were sent out to partners like the UNICEF, like the Goal International, the other partners in the country by them, to intensify community engagement activities. And after some period, that was maybe after 6 months, 5 to 6 month period, the district thought it wise that I should leave the chiefdom and come and head the surveillance unit in the district. It was a very hard time by then. It was very difficult because cases were coming from every part of the district. Every week we are having a lot of problems with people hiding away from quarantine homes, people hiding with sick people, moving with sick people at night, and all those things were happening. So when I came on board, it was very difficult for me in the first 2 months. First of all, when I came, I met a different structure built up now in the district, headed by military personnel. Not my usual DHMT personnel, but the military guys, which was a very good, very proactive system in terms of response. We are having 3 meetings every day. Excuse me. We are having 3 meetings every day. The first meeting we have is the surveillance meeting. It's a surveillance meeting that is to get feedback from other colleagues, other surveillance officers, epidemiologists that may go to different areas and may come back very late in the evening, which you cannot have meeting that. So we have like 7 o'clock in the morning, the first meeting that will last for 1 hour, 7 to 8 o'clock, so that we have feedback from the field and have a strategic plan for the teams to go out. Immediately after that first meeting, epidemiologists, some epidemiologists, surveillance officers, swabbing team members, we go to the field, to areas that need attention, areas that need surveillance activities, barrier activities to be done by the barrier team which was established in the country. There we go, leaving me and some other epidemiologists and some other key stakeholders to brief the entire team. You know, we are having flux of partners in the district, a lot of them, a lot of people. So you need to give them information about what is happening in the district, because they were supporting in terms of logistics, in terms of a lot of other things. You know, these partners, they also need information as well as the ministry. So when after the 7 o'clock meeting, we get this information from all these pillars, social mobilization, surveillance, swabbing team, then this is the information we'll present in the 8 o'clock meeting. The 8 o'clock meeting comprises of all the stakeholders. When I say stakeholders, the district Ebola coordinator, the paramount chiefs of all the chiefdoms most of the time, the ministers, the councillors, the council, and people from the Ministry of Health and all partners. It's always a very big forum every 8 o'clock. It lasts for something like 45 to 1 hour also. So that's the time we do presentations to tell them, hey, we've had situation in ABCD community, and we have ABCD quarantine homes, and cases, alert have just come in from ABCD community, and we are dispatching ambulance to this community. And all these updates you give to the entire team in the hall. Questions may come from which angle or all the rest of it, and also requests for support can be made right there also, because partners are there to give support, and all the support we are coming. So that is how we are responding. But the sad experience we had was in one community called Kadalo community, that was in Tonkolimba. Kadalo community, Tonkolimba specifically, is a chiefdom that is highly involved in traditional practices. When I say traditional practices, societal issues which are highly secret. And most of the time, if they want to conduct secret burials, they pretend to be having a societal meeting, which will only limit the ones that are part of those secret society. So that was the thing that was happening in those chiefdoms. One day, we were having, before coming to that, we were having specific surveillance teams. As God may have it, I have 20 surveillance officers in the district by then, and these 20 surveillance officers were distributed by chiefdoms, and every day, whether you have alert or not, you will be roving in that chiefdom, going round, just to make sure that nothing is happening that is not being reported. Luckily enough, one of the teams bumps into a meeting which some people were saying it was a societal meeting, which was not true. Not knowing it was a burial or something, they wanted to conduct a secret burial. And the formation of our team by them was the surveillance officer will go alongside with the burial team, the social mobilizer, the swab collector. They will all go together, but in different cars. The swab collector and the burial team officers stay in one car. The community engagement officer and the surveillance officer will go in one car. So it's like they were having two vehicles moving in one direction at every given time. Because when they meet a case, I mean a suspected case to say, they are going to investigate, engage the people. If it is a death alert, collect swab and do burial right there. Safe and dignified burial to say. So it happened, they met burial, collected swab sample, which an alert was not made for. And the corpse was already prepared. When I say prepared, washed, dressed, because in the event of Ebola, there was a policy which says every death should be reported immediately, and family members should not wash the corpse, either dress. It was only the safe and dignified burial team that was allowed to bear all corpses. In that situation, that was not the case. So the unfortunate things happened because of the washing, the preparation of that corpse, not knowing to them that it was an Ebola corpse. The story go like this during the surveillance investigation. Before us getting that result, after preliminary investigations, 4 deaths happened retrospectively before us getting to that death. This happened because the father of the disease, which we collected a sample from, is a traditional healer. And he was the one seeing patients who are sick. So to say that particular chieftain was not engaged enough in preparing the minds of traditional healers and the health practices for Ebola prevention. They were not well prepared. So it's like they were doing all their normal dates. They were doing traditional healers, they were treating people, and they were doing their burial as normal as they used to do. So when the result came positive, during the community engagement, giving them feedback about the outcome of the result, we had a rumor that there was a traditional healer there and he's sick. We tried to investigate to get the sick man to no avail. They were hiding the sick man. But one thing I learned in the Ebola, most of the time, people you expect to tell you the truth are the ones that may actually mislead you. People you think you may have confidence in, oh, this person may not hide anything, are the ones that will compromise situations and hide the truth. That was where we learned that experience from. And anyone you are falling up in a quarantine home, who every day when you go to make follow-up pretend to be healthy, keep an eye on that person. That person is not healthy. What I meant is that we had a situation going to a quarantine home to follow up some young guys, up to 8 of them. Every day you meet them pressed open, having this physio thing, doing some gymnastic activities. When they see you, they pretend as if they are healthy, jumping. We're okay. Every day they were doing this thing until one day one of them could not get up.
Okay. So I think you had just been talking about those guys who every time you checked up on them were like being super physically active and like doing push-ups and all this kind of thing.
Yeah, so actually those guys, so that was another experience we have, that if you are following up contacts in a quarantine home who that pretends to be very active, keep a close eye on them. They might not be very active. There is a reason why they are pretending to be healthy. We observed these guys closely, and one day one of them could not come out. That person was removed from the quarantine because manifesting something like fever. Not knowing all the rest, we are having self-medications in the home, with all the advice, the pieces of advice given to them in quarantine home, that when you feel any unusual, you have any unusual feeling, you should report immediately so that you can be taken care of. That was the reverse. They were treating themselves in the home until one of them actually could not pick up his head the other day. We have to take the person out. And he told us, based on the confidence we built with him in the treatment facility, he told us that all those other colleagues are really not well because they are all taking drugs. We had to go back there. It took us 2 days counseling them for us to take them out. The last day we went and took 7 of them out of the house, all of them who were pretending to be tested. We took them to the isolation facility in the treatment unit. We decided to take samples from all of them. We tested all 7 of them. All 6 were confirmed Ebola positive, and only 1 was negative for Ebola. So that was another very good experience we have. From quarantine home, if you are following up people, contacts for Ebola or any hemorrhagic fever disease, in a quarantine home, if you are following up people and somebody is pretending to be super active, keep a close eye and do further investigation on that person. That was a very good point we learned. Now back to this Kadalo community. We had to do day-to-day engagement in that community until the confidence of the people were built and they started talking. We got the traditional healer. He was sick. We took him out. He was confirmed Ebola. He died. We had contact line listed, following them up. They were getting sick every day. We were taking them out and they were dying. Then we came back to the panel and asked, why are people dying even when we are taking them out of the quarantine homes? We did further investigation and found out that when you are in a quarantine home and you start manifesting symptoms and you suppress it by taking medication, self-medication, by the time the team realizes, your system is already down. That was another point of message development for people in quarantine home as well. That if you are there, the moment you feel even headache or even sleeplessness, you should report immediately and we should investigate you further so that you can be taken care of in the treatment unit, and we'll start getting survivors after the development of that message. A lot of things happened really in that village. We ended up quarantining the entire village, a very small village with about 20 houses. We had over 11 confirmed Ebola cases, house to house. The first 2 quarantine houses, people were using backdoor entry to support their loved ones, even when they are not in quarantine, feeding them, providing medication and all this stuff. So they were carrying the virus from one home to the other house. We ended up quarantining the entire community and we followed them up. And luckily enough, we had some survivors, about 3 of them from that community.
How many people were in that community to start with?
The population roughly in that community was something like about 400, around 400
Around
people in that community.
And then how many of them got Ebola?
We had 11 confirmed Ebola cases, but a situation happened where a lot of them escaped the quarantine. We could have had more Ebola cases from that community, some quarantine. We even discovered one of them in the bush. We met the skeleton in the bush, which it is another story for that woman. When she escaped from the quarantine, she was, well, naturally she was very short, like a dwarf, very short woman. And they said she was a traditional healer, and she was so powerful that she can disappear. She can be standing there and disappear. And when she escaped the quarantine, that was what they told us, that she may have used her magical powers to disappear. We were really not very comfortable, but we had no other option. We were still looking for her until after the quarantine. WHO offered the community people donated some fund that for anyone who discovered even her skeleton, that person will get that reward. The entire community went into search. They went to one swampland and they saw the skeleton, the plastic, the torchlight she was having. And by description, you see her bones very short things, just like her. And the clothes she was having on and everything. Yeah, that was discovered. Now, came to the mind of people again about eating bush animals. Which animal could have fed on that carcass, on the woman's carcass? We start worrying also about that area. You know, we have a lot of thoughts during this Ebola, which even up to now we are not very sure. We are not very sure if we may not be having the virus around, because some people died in the bush. A lot of people escaped quarantine from different locations, and we never accounted for them, to be very honest. Could these people may have died in the bush, like what happened in Kadalu? Yes, or maybe no. Could these people may have crossed to another country and they died there? They were not accounted for. These are all possibilities. So these things happen. So from those experiences, we brought in the military guiding the quarantine homes as well. So okay, if we quarantine a home, let's have security to guide, not only for people not to escape, but also their properties, because when people are quarantined, a lot of support are given to those quarantine homes, which other homes that are not quarantined are not getting. They may tend to come in there to benefit, and during that process, they are contacting the virus and taking them home. That was another thing we learned from the Ebola response, which at the end tail of the Ebola, like the Ebola ended in Gambia here. Ebola ended in Gambia, and the strategy we were having, the latter part of it, was that every community Ebola is confirmed, we have to do a massive quarantining, because nobody was sure of nobody now. People were not honest. People were not saying the truth. So because of that, there's a smaller community and Ebola cases confirmed there. We will prefer, irrespective of the cost, to observe everybody in their respective homes and giving them all necessary support, so that the crisscross movement, people moving from other homes to quarantine home because of the support, may be limited or may be stopped. So these ones we are put in place, and that helped us a long way. That brings me to the last case we have in the district. That is Selakafta. Selakafta, the case was having a link to this same Kadalo community I've just spoken about. It was also a confirmed swab result. From that one case, we also had 6 other cases coming up. Luckily enough, that was the most successful quarantine we ever had in the district, or maybe in the country. Having 6 confirmed cases with only 1 death. All survived. All the 5 survived. That came about as a result of the community being under quarantine. Because if somebody is sick, you have nobody to actually find new way to escape, because everybody is restricted in their various homes and there are security personnel around and all the rest of it. And the surveillance activities were so intensified that almost everyone was concentrating, in as much that was the last point. We had cases. People were there day and night monitoring. In fact, contact tracers were monitoring people 4 times a day. 4 times. Because you may not know if somebody is taking self-medication, but you will not take self-medication 4 times. So if you are getting sick within the day and you are monitored 4 times, they may notice you within one of these periods, these monitoring periods. And that was another very good strategy, that people in quarantine home should be monitored, not within normal. As I say, morning, evening, no. It can be 3 to 4 times, so that, it causes you no harm, and you may actually get the desired result. Because people self-medication, you cannot stop. But if you really monitor people 4 times, somebody may not take drug 4 times. One of those times, you must, especially for fever, you must identify that. And close monitoring, you must come across another manifestation of other symptoms. So that was another thing we put in place, which made that quarantine very successful. And from that case, we came back, sat and discussed so many things that we think can really improve the surveillance and improve the response activities. That was where partners prepare proposal for Resilience Zero. Resilience Zero means, to my understanding, is to keep the district or the country under a microscopic eye in terms of continuing, especially surveillance activities for early detection and investigation response activities, so that cases that may be identified can be contained within that particular area and having a better result. That is where Resilience Zero initiative came from as well. And up to now, that's what we are having. And we also had this IDSR, Integrated Disease Surveillance Response, that is adding more strength now to the surveillance activities and taking the surveillance activities to community level, which is an indicator-based surveillance from health facilities. This also started the Cambia district. We had the first training in December 2015, and we started that throughout 2016 with the help of WHO, CDC, GOAL, other partners support. We have been able to get at least 2 health workers as focal persons trained on integrated disease surveillance response. on early detection and reporting of priority diseases for the country, and also put a system of having district surveillance office, having an alert system, having a district EOC that is responsible for coordination of response activities when once the surveillance detect any unusual happening. Going further, also we have this community-based surveillance that is involving community people in the surveillance activities that we call active community participation into surveillance activities by detecting cases and reporting to the nearest health facilities, because the health facility staff are highly technical. The community may not actually know the difference or how to screen cases meeting standard case definition, but the health workers can do that. But we gave the community workers, community health workers, basic knowledge, basic definitions on 10 priority disease conditions that they may detect and report to the nearest health facility immediately, and the health facility staff will take the responsibility to screen the patient as permitting standard case definition and inform the district. There we can respond. So that's the kind of system we have right now, and that is what we are actually still trying to strengthen in the district. And in 2016, the surveillance in Cambia district reporting rate, we have been struggling with reporting. Actually, the start of any program may have a lot of some hiccups, a lot of challenges. But our reporting in the beginning in 20, you can see 2016. You can just see a trend here. Something like 2016. This is just a trend to 40.
Percent trend of PHUs reporting Cambia district.
Yes, that is it. So percentage, because we have 69 in 2016, 69 health facilities, which are IDSR reporting sites, and all these reporting sites are expected every week, every Monday. Epidemiologic week starts on Monday and ends on Sunday. So the next week, Monday, that's the time you report for the past week. So we expect that every Monday for the previous week, all PHU staff look into their registers, report to us all the cases of priority they have seen in their facility before 12 o'clock or on 12 o'clock. We get this data, collate them, and that's where we derive the percentage from in terms of PHU reporting. And we send those aggregated data to the ministry. But also, within the week, diseases that are immediately reportable. If anyone is being detected by the health worker, they inform us. We are going there to investigate. We go there to investigate. We go to the community to do some active case search through the active involvement of community people, engage them so that we can be sure if it is just one suspected case, it's one. If it is more than that, like in the area of measles. In 2016, we had a huge outbreak of measles, which was detected by this system. Because the system, we are detecting cases, and we are getting collected samples. All those things. We have a massive campaign, which actually brought the trend down to, So something like that. These are the systems we are having at the moment, even though it's not 100% yet, but we can say our system at the moment is capable of detecting at PHU level. At community level, we have just started. and we are still struggling to strengthen that as well. And my belief is, if the community-based surveillance work well, we can go to bed and sleep, because disease comes from community, and if these community people have the responsibility and they actively see this responsibility as something for the benefit of the community by detecting cases and reporting them earlier enough, may help the community, may help that family, and may help the country as a whole. And that may improve our surveillance system in the country. I think so far that is what I can share.
Sure, of course. Would you mind? I have a couple of follow-up questions.
No
if you
problem.
don't. Okay. One is, sorry, I have a few of them here. Going back to your Ebola times, right? The international partners you worked with. Can you tell me how they were useful and how sometimes they weren't?
Thank you very much. To be very honest with you, Sierra Leone, when Ebola struck, we had no expertise. We had very little, or even I could say no knowledge about Ebola. Had it not been the presence of the partners, maybe the level at which we were able to work and contain the disease, I could say, if it was not the involvement of the partners, we may be still having Ebola in the country. Maybe some of us will have gone. Ebola may have carried us, because one, we never knew even how to investigate the disease, how to control the disease, the message of the disease. That brought a lot of conflicting. Everybody in the corner may just bring their own information. But until when these partners came, they brought out the facts, key facts about Ebola from experience in other endemic countries where Ebola is actually striking every now and then, before we can have the knowledge. In terms of epidemiology, the country was not having, well, I can't remember if Sierra Leone was having any qualified epidemiologist as a Sierra Leonean. I can't remember. Maybe there was one or two, but I can't remember. But the advent of the partners, they were very useful in terms of capacity building, which made some of us today to say, yeah, we can investigate and we can give some quality reports on case investigations or outbreak investigations. They were very useful. They were very useful in terms of supporting the ministry, the district, and the response activities in terms of logistics. We had no cars when we started Ebola. The same ambulance we are using to bring like pregnant women, referral for our normal cases, we had the ambulance we are using to bring suspected Ebola cases. There was no ambulances in the district. Even as that, we had no field support. So without the advent or the intervention of the partners, we were nowhere, to be very honest.
Which partner helped with the ambulances?
Defeat.
Defeat did.
Defeat did that. Defeat bought a lot of ambulances for the country.
What did CDC do? What was their role?
CDC, WHO were very instrumental. One, in capacity building. Two, actively involved in case investigations, the containment, all the response activities. We were actively involved in that, and they were providing some logistical support as well. Okay, like most of the trainings we are having, CDC was conducting those trainings. WHO was also conducting those trainings. Okay, different trainings. They were providing tools, like the CIF we are using the case investigation forms were provided by CDC for VHF. This is viral hemorrhagic fevers. CDC provided the VHF database that we were using here. So they were very useful. WHO was also providing field support, vehicle, and those supports we are giving to the DHMT by them till defeat later on procure these ambulances for the district. So they were very useful. From them we learned a lot. And even now we are still learning. I never knew anything about computer. I was in my village there. I don't even have a phone that is having internet, but with the interaction with these partners, CDC and WHO, now I can say, well, I can do basic analysis. I can manage my data. I can read my data and make sense to people. And those things, these are things we are actually very proud of. That is a legacy now. And luckily enough for us, an epidemiological training have also started in the country, which is also another very, very important capacity building aspect for the Ministry of Health and the country as a whole. The country was not having epidemiologists, and now CDC is helping the country to have epidemiologists in the country, which is a plus to the country, which is a very good thing.
This is the Field Epidemiology Training Program?
Yes, the field epidemiology.
Which you yourself have gone through.
I have gone through. I was part of the first cohort. We are the first batch that went through the FATP, which sounds very interesting to me. Which actually I am inspired to do further epidemiologist course if I have the support. Really, I'm really impressed to have this public health studies.
Why did you decide to do the program?
Why I decided to do the FATP program?
Yeah.
Because I look at the FATP program to be an eye-opener for me to go into epidemiology proper. As far as surveillance is concerned now, it's not only going to the field, how many cases you line this and stop there. No. You should have the skill, the knowledge to analyze your data, interpret your data, make sense out of it, and communicate your findings. Then you can plan to actually know how to prevent the people in the community down there. So that kind of stuff, you can only achieve that if you are actually trained on the epidemiology course.
Has that training impacted your work yet after you graduated, the training you got there?
Very positively. That has also inspired my colleagues, because as I graduated, another colleague have already graduated, and we are also trying to send other colleagues to start the program, because we are always seated together and they are seeing the wonders we are doing with this Excel, this bringing powerful presentations, very nice, So everybody is inspired, want to be part of it, want to do it. Every surveillance officer want to be an epidemiologist. So it is very, very important.
Ask something about the international partners.
Yes, some of the things that never went well.
Yes.
There were a few things, what we actually learned from the response as far as the partner support we are coming. Yeah, we are so pleased. But again, we have too many partners. At the end of the day, they were duplicating efforts, which actually in resource management was not well done. A lot of resources were used extravagantly. somebody may be doing this thing and the other person duplicating the same thing over and again.
Can you give an example?
Yeah. Like for example, we were having a lot of community engagement officers from different partners. This partner may say, I have 500 community engagement officers. This partner will say, I have 1,000 community engagement officers, which most of these people we are playing dual role. It may be the same person with this partner, the same person with this other partner. Okay, the same people playing just to have money from this partner, have money from this partner. So in short, the coordination with partners was not very, very strong in the beginning. So everybody was doing their own thing, which actually, from experience, I think a better coordination in partners' effort in the future would be the best thing for every outbreak response. The support is needed, is fine, but the coordination, so that one cannot duplicate the effort, and even the resource management, can be also, the resource management can also be effective. One thing I did mention in the response was the intervention of the CCC. I did mention CCC, Community Care Center, Ebola Community Care Centers. How did this come about? In the response, we are taking people from the community, transporting them to Freetown, transporting them to the district here, just to isolate, take sample to know whether it's confirmed or not. And the community people will have a lot of resistance, because they may want to have their people isolated in their chiefdom, in their locality, and be tested before evacuation. And they were making it very clear to us that if we want to take somebody out from their community, that person result need to be known first. And they will only allow us to take people out of the community, even when they are sick, when the result of that relative is confirmed to be Ebola. Then after a group discussion, UNICEF said, okay, I will give the support. In every chiefdom, we are having an isolation facilities built in those chiefdoms, not as taking sick people now from Bremaya chiefdom to the district headquarters town here. And also to limit the transmission of the disease in the district headquarters town, because we are having infection, may either on the way or on arrival or in the ETC or in the isolation. So we started isolating people now at their community level, take their samples right there, send the sample to the laboratory, and the result determines as per whether the person is having Ebola or not. Yeah? Yes, that was also another thing I forgot to mention, which is another very good strategy for communities that are having limited knowledge on diseases like Ebola. It will be better for people to be isolated in their locality, followed up until their result is actually confirmed to be Ebola or the disease you are isolating for, before taking the person out of that community. So that one, you build the confidence of the people. Two, the people will have access, not actually get in contact with the person, but may have access to hear information about their relative and maybe see their relative from a distance, and all those things. Confidence building, that's very key, that I did mention.
Thank you for that.
Yeah.
I have one question also. Did you ever have the opportunity to ask people who had escaped quarantine what motivated them to escape?
Okay. I think yes, that was actually investigated, because many people were staying in quarantine throughout the period, and many people were running away. They were escaping quarantine. Reasons behind that were misleading information from other people. Like in the country, as I said, we have limited knowledge on Ebola, and people were having misleading information.
Okay.
People may call from Freetown, they call their relative in quarantine. Just leave that quarantine. The government want to make money out of you. They will be collecting your blood to go and make business and all those kind of things. People were scared and they were escaping quarantine. That was happening in the initial and even in the mid of the response period. These things were happening. So a lot of people were, because of fear, they were just afraid. You know, we have this infrared thermometer. They were calling it pistol. Infrared thermometer. When you check, it looks like a pistol. You're checking them. So when they point that thing on you, they are, you know, so a lot of things are. So people were having misleading information on the use of that thing. So they were afraid. So most of them were escaping the quarantine.
Sure.
Yeah.
Sorry, I see you checking your phone.
Somebody was calling.
Okay. Do you need to end the interview pretty soon?
Yeah.
Okay. Gotcha. Okay. Let me just ask you then, Mr. Osman Barrie, first thank you again for giving us your time.
Okay.
Is there anything else that we have not described? I know you just talked about the CCCs, but any reflections or any memories about your Ebola experiences which you would like to share before we end the interview?
Yeah, I think a couple of them have already been mentioned, but I think the Ebola that came to Cambia district specifically make us actually have a lot of experience in terms of outbreak response. First of all, planning for an outbreak, because from the experience we have, the country never planned for an outbreak, not to talk about the district. We had no plan. There was no plan. So that was one thing actually. Even now the ministry, we are always talking about district plan, emergency preparedness plan. Always be planned, not only for Ebola, but for all other diseases that have the potential to cause an epidemic. Like cholera. Of course, we are in a district, cholera prone district. Most of the time we have cholera in the district. So that is one thing. It taught us how to be having emergency preparedness plan, and also to be triggering ourselves as per whether we are actually up to task, having simulations. You know, that is another thing that is the Ebola actually taught us, and having the coordination unit. You know, when Ebola came, everybody was doing their thing. It was not well coordinated. But now having a coordination structure at the district level, it is something very, very remarkable. That every district is having a district emergency operating center, and when something happens, you can immediately call all your partners and your stakeholders, and you discuss, plan how to respond to it. That's another thing that is very key, I think.
Sure.
That is very remarkable. We can continue it.
Perfect. I just want to thank you for your time, for your reflections, for everything. Thank you. Thank you.
Thank you
so
very much. I'm also pleased to have you with me.
Thank you.
Yeah.